Good evening, everyone. Each of our distinguished panelists will make opening remarks on issues that are particular to their field and their experience. And we hope that you'll take notes as you listen and consider jotting down particular questions for them. Yes, put their name at the top of your question. That would be helpful. The other request, of course, would be to write legibly. The only doctor in the room that I know so far is this guy, so you all write better, all right? And lighten up, you know. I mean, we're here to enjoy each other's company and to learn a lot tonight. So we will take as many questions as time allows. We finish at 8:30, and so I'd like to begin by introducing our panelists. At the far end, Maxine Slappey from Storm Lake, Iowa. She recently retired from being an elementary school, middle school principal after 18 years. Carolyn, did you know that about her? Did you two bond? Okay, good. That's good. Currently, she is the state president of the American Association of University Women. And in that capacity, she helped facilitate a statewide project called the Iowa Initiative, a project which brought many resources together with the goal of reducing the number of unintended pregnancies in Iowa. Maxine is a member of the Iowa Women's Leadership Project, which researched the status of women and girls in Iowa and published the report entitled She Matters. She is a very active community volunteer. She's committed to a number of projects, including Camp Hope, a camp for drug-endangered children. Maxine tonight will be addressing gender equity in the workplace and in athletics. Not in the same order. Now I'm switching to Peter. He's the man there. He's the director of the University of Iowa Public Policy Center and is a professor in the Department of Preventive and Community Dentistry. He is a health services researcher studying access, utilization, and quality of care. His funded studies are primarily in the areas of healthcare reform, maternal and child health, health disparities, and healthcare for underserved populations. He's authored over 100 journal articles and research monographs and has been principal investigator on over 50 funded research studies. He continues to provide dental services to physically and mentally compromised patients at the University of Iowa's faculty group practice. And tonight he will be discussing components of the Affordable Care Act, Medicare, and Medicaid, and implications for women's health issues. Liz Hoskins, immediately to my right, has served as the Executive Director of Waypoint Services for Women, Children, and Families for the past 13 years. Over the past 35 years, she has served in a variety of positions at St. Luke's Hospital, Kirkwood Community College, De La Rue PLC in the United Kingdom. As a longtime resident of Cedar Rapids and Marion, she has served on the board of directors of United Way, Planned Parenthood of East Central Iowa, the Lynn County Nonprofit Resource Center, the Housing Fund for Lynn County, and the Iowa Coalition Against Sexual Assault. Liz graduated from Mount Mercy in 1980 with a bachelor's degree in psychology. Waypoint, formerly the YWCA of Cedar Rapids and Lynn County, has been serving women in the community since 1894, providing shelter and support for women and families in crisis due to homelessness, poverty, domestic violence, or sexual assault. The organization also provides quality, affordable child care to over 500 children in the Cedar Rapids metro area, offering financial assistance to those families who could not otherwise be able to afford care for their children. Our fourth panelist is Katie Jones, a health education specialist with the Lynn County Public Health Department. She recently graduated from the University of Iowa with a master's degree in public health. She has been passionate about women's rights since high school and is also interested in health communication and chronic disease prevention. Katie collaborates internally and externally on a wide variety of projects. She facilitates community coalitions and implementation of grants. For example, she is currently working with landlords who are interested in adopting smoke-free policies as part of Lynn County Public Health's Community Transformation Grant. Katie will provide some background and facts about Title X, the National Family Planning Act, and local resources for family planning, preventive services, and she will also provide information about the Sexual Health Alliance. So let's give all of our panelists a big round and welcome them. And Maxine, we are starting with you.
Why is pay equity an issue? First of all, job creation and economic opportunities are critical issues for women, many of whom continue to struggle with economic insecurity and wage discrimination. But most importantly, women working full-time in the United States still earn just 77 cents on average for every dollar earned by their male counterparts. African American women make 64 cents on the dollar, and Hispanic or Latino women make an average of 55 cents for every dollar paid to white, non-Hispanic men. Iowa's median income, and this came from the U.S. Census 2010, women's earning in Iowa on the average is $34,534, and men is $43,872. That means women in Iowa are earning 79% as opposed to the 77%. The wage difference would pay for 82 weeks of food, 8 months of mortgage and utility payments, 14 months of rent, 29 months of family health insurance premiums, and 2,312 gallons of gas. And this is for a single woman or a single mother with 1 or 2 children in Iowa. Why should I care? Well, the wage gap has real consequences. 2/3 of women in the workforce function as the primary or co-breadwinners for their families. Wage discrimination undermines families' economic security, it limits women's choices, and it lowers their ability to buy homes and pay for a college education. It limits total lifetime earning, thereby reducing retirement benefits, which is a huge issue for most of us. Why do women make less? Well, first of all, women often underestimate the market value of their work. A number of women are in positions as secretaries and areas that there aren't very many men. And so employers say, well, we don't have to pay them as much because obviously the women are going to work. Men expect to earn 13% more than women in their first year and 32% more at their career peak. How can I make my voice heard? Vote. Hopefully you're all registered to vote. Find out where your officials and candidates stand on the issues, and tell your senators and representatives to pass the Paycheck Fairness Act. Now let's move into Title IX. Title IX states, no person in the United States shall on the basis of sex be excluded from participation in, be denied benefits of, or be subjected to discrimination under any education program or activity receiving federal financial assistance. Now normally when we talk about Title IX, we're talking about athletics, but there is a broader range to that, as we'll see in a little bit. But right now I'd like to focus a little bit on Title IX and what it requires for athletics. offer female and male students equal opportunities to play sports. I think you're all aware of that. Treat female and male athletes equally in all respects, including equitable equipment, facilities, and coaching. That means the girls don't get the hand-me-downs from the boys' teams for the following year. Give female and male athletes fair share of athletic scholarships. How can this be demonstrated? The percentage of female and male athletes is proportional to the percentage enrolled in the school. So if there are 50% women, then there should be 50% women in athletics, or at least have that opportunity. The school has a history and continuing practice of expanding opportunities for underrepresented sex, and the school is fully and effectively meeting the athletics interests and abilities of the underrepresented sex. You can check with your own school to see if equipment, supplies, and uniform are equal, practice and game schedules and seasons are equal, travel and transportation for games, matches, and meets are equal, opportunity to receive coaching, compensation for coaches, lockers and facilities, medical and training facilities, housing and dining facilities, publicity, and Title IX coordinators need to be known by all. Title IX also opens the doors for girls to pursue math and science. It requires fair treatment for pregnant and parenting students, and most recently, it's come to all of our attention, it protects students from bullying and sexual harassment. In the 2007-8 school year, girls made up 49% of the high school population, but females only accounted for 41% of the participants in athletics. The High School Accountability Act still has not been passed. Even though it is a law, there's no way to check if the schools are accountable. Women make up 54% of all undergraduate students at the college level, but the female share of athletics is only 45%. This is a chart to show collegiate sports positions by gender. You'll see athletic directors, 81% men, women 18.6%. Head coaches, men 57.6, women 42.4, and head coaches of men and women's teams 82.3% and 17.7. So you can see the disparity of the head of each of those positions. Disparity in funding intercollegiate athletics is huge. Scholarships, Division I, you'll see that the men are earning about double almost. The women have the bottom number. Division II, men $630,000, women $477,000. Division III, it's not applicable because Division III schools are not to give athletic scholarships. There are ways around that, however, that they have found. In recruiting, if you'll notice the huge difference, most specifically in Division III, men $18,400, women for recruiting, $9,800. Women who have the education, employment, and assets to provide a meaningful and healthy life for themselves and their families are economically secure. To meet this goal, women must be safe, be educated, and employed, have access to health care and child care, and have equal opportunities for career and leadership advancement. Once these needs are met, women become independent, vital, and contributing citizens of Iowa. We can do better, and we will do better. The time is now. The leader is you. If not now, when? It's a simple matter of fairness. Thank you.
Our next speaker is Dr. Damiano, and he is going to be talking about Affordable Health Care Act, Medicaid, and Medicare.
Okay. Can you hear me okay? First, I want to thank the American Association of University Women Cedar Rapids chapter for the invitation tonight. I think this is a great type of a forum to discuss these different issues. Healthcare and women's health, you may have noticed, is beginning to play a little bit in the election and in some of the discussion. I'm not here to talk about the Affordable Care Act or Medicare and Medicaid from a political or advocacy perspective, though. What I'd like to do is just kind of talk through some of the issues related to these three and then hopefully get into some sort of a dialogue. But when you think of Medicare, Medicaid, and the Affordable Care Act, what do those three things have in common? Why would we be talking about those things together? They're government run to some extent. And Medicare and Medicaid are. The Affordable Care Act, there's actually a lot of private components to that. Can you think of something that sort of runs through that, a theme through that? Yes? Funding for health care. Right. They're all, the things that we think about related to these have to do with health insurance coverage, right? And financial access to health care. Access to health care can mean a lot of different things. We often focus on insurance, but it can mean everything from language, culture, geography, comfort. A lot of things determine whether someone has access to care. But in this case, the thing that with the Affordable Care Act in particular, we think a lot about, but definitely with Medicare and Medicaid, what it has to do with financial access to care. And if you think about the insurance coverage within the United States and the history of the United States, when did we first get into sort of this idea that we have employer-based insurance? Anybody know?
World War II.
Right, World War II. And why did that come about?
People going to war and learning people in the workforce was having, and they couldn't do stuff about their prices and wages were frozen. So they had to entice them by using other benefits.
Right. We had a wage and price freeze on in the United States. There was a shortage of adult male workers in particular. And so to be able to attract and retain people, they started offering health insurance benefits. It wasn't that this was sort of planned because we have a free market system. It just sort of happened. Then the next big expansion in insurance coverage was in 1965, and that was when Medicare and Medicaid went into place. And what do you know about the Medicare program? Who is that for primarily? Primarily people over 65. It is tied in, it's another one of the components of the Social Security Act, and also for people with disabilities, right? And who is the Medicaid program for? Low income. And again, people with disabilities. Do you know where most of the money in the Medicaid program goes? I'm sorry, but on what types of services we spend most of the money in Medicaid? Nursing homes, right. Most people think of it as a program for low-income moms and kids, and it is, but most of the money actually goes to people in nursing homes, and that was not something that was intended in 1965. That was really an afterthought. It was really, again, put in place for those low-income moms and kids, but it extended into that. Then in 1997, we came up with the Children's Health Insurance Program. In Iowa, we call that Hawkeye. And so then the Affordable Care Act is really the next step in that process of trying to cover these missing populations. And so we've taken the highest risk, highest cost people and brought them into government insurance programs with the low income and disabled populations and nursing home populations in Medicaid, seniors and disabled populations in Medicare, and then low-income kids who, again, are actually, for the most part, pretty cheap, other than children with special health care needs. And now with the Affordable Care Act, the idea is picking up all those pieces and parts that are left after that. And if you think about who the uninsured are, those people that are left right now, anybody know who falls into that category and why are people uninsured these days? Okay, it might be that they're unemployed, young adults. And right, actually 80% of the uninsured are working people and their families. It's not that there are people who are unemployed, but it isn't that these are people that aren't working or aren't trying to work. They just happen to be working at low wage, low benefit type jobs. And with about 2/3 of them making less than $50,000 a year, it's very difficult for these folks to be able to go out and purchase individual or family policies. Because an individual and family policy right now in the United States is about $15,000 a year on average. Now there's different options. But the thing about the Affordable Care Act, that if you remember nothing else about it and the discussion, is that the main thing that the Affordable Care Act from the insurance component side that it was designed to do was to help people who literally purchase individual or small business policies. Now, most employers in the United States and most people that get employer-based insurance, the companies are actually self-insured. And the majority of the aspects of the ACA do not have anything to do with employer-based insurance. There are some components, and actually some of them that are related to women's health and preventive coverage, that does. But most of this is aimed for that individual or small business person that literally goes down to the Farm Bureau office and purchases a Wellmark insurance product. And those are the ones where you had the pre-existing conditions before, you had the annual maximums, you had lifetime maximums, you had somebody that had bought an insurance policy, got sick, gets dropped. This is what the Affordable Care Act is really designed to try to do, is stabilize that individual and small business market. And so when people go out and purchase it, they have some idea why what it's going to be like in the future. Now, do you know why we've got the individual mandate component? We focus on that a lot, right? And a lot of the angst about this and the government takeover talk and all of those kinds of things. But why is there the individual mandate piece? To keep costs down, but how does it keep costs down? Right, everybody is then in this pool, but it was actually driven by the insurance companies, not by the government, because the insurance companies said, we will only go along and get rid of pre-existing conditions and annual maximums and lifetime maximums for these individual and small business policies if you get and bring everybody in. Otherwise, if only the sick people or the people with the pre-existing conditions were to go and try to buy these policies, the risk is obviously going to be very high. And we've had the establishment of high-risk pools already as actually in advance of the ACA, but as a part of the ACA, when children at the beginning of this, they got rid of pre-existing conditions for kids, and they started covering kids on parents' insurance policies up to age 26. You're probably familiar with some of those policies. Well, they didn't do the same with adults, and so they tried to do these risk pools, but what they're doing is pooling the highest cost, highest risk people together, and the high-risk pools are still very costly. And so that individual mandate is actually being driven by the insurance companies that said that we're only going to go along with this if you bring in the low risk with the high risk. And so the ACA is really a combination, it's being sold many times by opponents that it's a government takeover, right? And that it's this government program. And there is a piece of that. So the way that the insurance coverage part of that is going to work is that everybody up to 133% of poverty will now be eligible for the Medicaid program, regardless of what category you fit into. We'll talk about that, and that's an issue of where the first kind of component about covering women that were not covered before comes in. And then from 133 to 200, it's not exactly clear. There's some different options, but then from 200 to 400%, people are going to be driven into these private health insurance exchanges, which is something like going to Expedia and you're going to be able to choose among different subsidized health insurance plans, but these are all private plans. And so we're actually going to be driving more people into private insurance plans than are going to be going into public plans. Again, one of the things that you don't hear a lot about it. And one of the first gaps that I just kind of want to mention in terms of coverage for women is with particularly single women and men with the Medicaid program. Because right now, to be eligible for Medicaid, you both have to be poor and you have to fit into a particular category. So you have to be a poor disabled person, or you have to be a poor mom, or you have to be a poor child. But if you're a poor single adult, you're not eligible for Medicaid right now. So the first thing is to do, we're going to get rid of all the categorical eligibility and just cover everybody up to 133% of Medicaid and kind of call that one done. Then from there, it's going to be based on your taxes and what you submit in terms of what eligible subsidy or what the subsidy is that you're going to be eligible for when you're going to purchase that private health insurance through an exchange. Okay? Does that make sense how that's going to work? So there are going to be many uninsured women that are going to be getting picked up by the coverage of Medicaid, particularly single women. Then we've already picked up about over 1 million women by putting them onto their parents' insurance policies up to age 26. So that's particularly people who graduating from college or are in lower wage types of jobs that don't provide benefits, and they're able to stay on their parents' insurance policies And that's one of those sort of low-hanging fruit, if you will. It's relatively low cost to do that. Adults in that age category, both men and women, are very cheap, other than some pregnancy issues, and particularly if there's a low birth weight delivery or something like that. Otherwise, it's very inexpensive. So we're covering people, particularly women, with a Medicaid expansion, with covering on your parents' insurance policies, and then going on to the exchange and purchasing that subsidized private insurance. Now, who's going to be missed by that? Well, they're estimating that about 32 million of the 50 million uninsured in the United States will get picked up with health insurance through those two mechanisms. And if you know who's left in that estimated 18 million who aren't getting coverage. Right, undocumenteds who are here are not eligible for any of these. Then there is a, you're going to have people that are just going to opt out, and you can pay a penalty, which the penalty right now is going to be very low if you choose not to go into it. And then there's also going to be people who can get a waiver because they're so low income that even with the subsidy, because there's a lot of the things about this that the rules and regulation are still being put into place. And so we don't really know how this is going to play out. Is the subsidy going to be enough, for example, that if you're at 200% of poverty, are you still going to be able to afford it? So if you've got a single mom with a couple of young kids at 200% of poverty, the subsidy and what they're going to have to pay still might be $2,000 to $4,000 a year. And so it's not clear whether they're going to have to be able to afford that. But on the other hand, how much can we continue to afford to subsidize the private insurance companies to be able to do this? So we've got a real trade-off there in terms of what's going on. The other aspect that you've been hearing probably a fair amount about is preventive coverage that's being implemented related to the ACA and in terms of women's health. A lot of publicity this year, but if you go back a couple of years, first there was required coverage of what's called preventive services that basically have been proven to be effective. And that's by the U.S. Preventive Task Force. If the preventive services that have been ruled to be successfully documented to be successful as a preventive service, those had to be covered both under public and private insurance with no subsidy. One of the big changes then with Medicare is that when Medicare was originally started in 1965, it was not designed as a comprehensive insurance program. It was really just like Social Security. Social Security was never designed to be the total retirement package for a person. It was supposed to be one leg of that three-legged stool with your individual savings, your pension, and Social Security. Same with Medicare in terms of payment for health insurance. But over time, the expectation has become that Medicare should be comprehensive coverage, and the ACA is really moving it in that direction. We had the Medicare Part D that went into place a couple of years ago with the prescription drug coverage. That was a big move in terms of making Medicare much more of a comprehensive insurance plan. You might be aware with Medicare, you've got Part A, which is the hospital coverage, which everyone gets. Part B, which is physician services, and it's not automatic, but almost everybody buys that because it's relatively inexpensive coverage for physician services. We have Part D, which came in for the prescription drug coverage, and now with the ACA, the expansion is going to be moving it much more towards preventive services and coverage of those things, plus the closing of the donut hole that you've probably heard about with Medicare Part D, that when they first put Medicare Part D in place, they were trying to keep the cost down, so there's a gap if you go beyond sort of the basic amount of coverage. Before you get to this catastrophic amount, you don't have enough coverage there, and they're going to slowly close that up to 2020. And so that's really one of the big changes. And with that Medicare preventive coverage comes mammography and a lot of other women's health coverage for preventive services, well, women visits and things like that as a part of Medicare that were never there before and were never intended to be there from the beginning. But now, again, as we're trying to make it much more real comprehensive insurance coverage, that's a piece of that. With Medicaid, you have a similar type of situation, but it's been better in terms of what services are covered with Medicaid, and particularly for children. the EPSDT program, which is Medicaid for kids, has always been the most comprehensive insurance program that there is in terms of what it covers. Now, if you talk to healthcare providers, they may not like it, it doesn't pay that well, but it covers basically everything that kids need, and on preventive schedule, periodicity schedule for immunizations and well child visits and all those kinds of things. For adults, some of these things have been mandatory and some of them are optional, and a lot of these things are going to become mandatory over time in terms of covering preventive services. Then for this year, in terms of preventive coverage, you started having first the coverage of non-covered services for people with private insurance, and then more recently in August, and this was where a lot of the reproductive health discussion came up, is coverage for reproductive health services and contraceptives as a part of a mandatory for all insurance products. And we can talk about that if you want to and sort of how that's played out, but I think that's been a big change in how we think about coverage for people, is moving much more in this preventive way. Now, prevention does not always save money. And while it's always generally a good thing to do, it isn't always less expensive, because you're going to be covering people for some things that they're never going to get. And if you really do the cost benefit kinds of things, just on a cost perspective, prevention isn't always cheaper. And so you have to be careful trying to sell prevention on that. But from a quality of life perspective and what we should be doing as a society and all those kinds of things, that's where I think it's better to try to make the argument on why we would want to be working on adding prevention to these different programs. One of the sort of the takeaway, if you will, or where we are at right now in Iowa, we've got about 2 to 3% of children that are uninsured. We've done a very good job of covering kids. We're at about 11 to 13% of adults that are uninsured in Iowa, which is better than the national average, but still have a little bit of ways to go. We've created more safety net programs for kids in the past. That's why we've got a lower rate of uninsured. But with the Medicaid expansion and the health insurance exchanges, then we'll be able to cover women who have been falling through these cracks and for many of these services. But the state is really struggling right now with the implementation. And you've got a lot of the just administrative kind of things that are going to have to be going in place. And this is where I would suggest, for those of you who care about these issues, really keeping an eye on this, regardless of what happens with the election, is that you've got the health insurance exchanges that are going to be going into place, and how is that going to work? And how accessible is it going to be, and what is the cost structure going to be? That's going to be critically important. What are the products and what are the different companies that are going to be going in and selling their services through the exchanges? What are their provider networks like? Are they going to cover the types of healthcare providers and women's health providers that you might want? And keeping an eye on those kinds of things, that's going to be critical. You've got the health information network that's being set up. These are some of the things that aren't talked about as much that I think you should be aware that is going on, which is a way to connect electronic health records. A lot of money from the ACA has gone into helping establish electronic health records with providers. Huge improvement. It's a little frustrating right now for many. Some of you might work in clinics where you're trying to deal with a new electronic health record, but over time, the connectivity and the be able to, when you go to multiple providers and somebody can pull up your record or your MRI or your lab tests or something like that, you won't have to have those duplicated. That's going to be huge. And that leads to the development of what's called health homes. And I don't know how many are familiar with the concept of medical home or health home, but this to me is really the most exciting thing coming out of all this, and what's going to be really important in terms of holding down healthcare costs and improving quality at the same time. And that's the idea of your primary care doctor being networked effectively with community resources, community utility kinds of things. It might be WIC, might be mental health services, through care coordination and care navigators, and getting you to the services. If you look at where we spend all of our money, can you think of the kinds of disease categories where we're spending most of our money? You know, not all of us use the same amount, right? What are the things that you think about where we spend most of our money?
Cancer.
Diabetes is huge. Cancer, heart disease, stroke, asthma, COPD, all of those kinds of things. Many of the ways that we're going to both improve the quality of care and hold down costs aren't because of things that physicians or hospitals are doing. It's going to be people working with the people with those conditions to try to help with nutrition counseling, to help with exercise, to help keep them from the hospital readmission after they've had an event, to keep them out of the emergency room so they know where to go on the weekends and evenings. And they're starting to be put in a system of care around this idea of health homes, and that's something that I think can be really, really helpful, and particularly when you're talking about the types of women's health that you need sort of the comprehensive types of services from multiple providers. That's something that I think is going to be really important. So right now, I would suggest the implementation is where to put your thought and interest, and regardless of what happens at the election, there's going to be a lot of these things that are going to be carried forward, and the issues that we're trying to deal with the AC aren't going to go away. So thank you.
Thank you, Peter. Our next speaker is Liz Hoskins, who will discuss the Violence Against Women Act. You're welcome.
Yes, I'm sorry.
Sorry about that. Got to get organized. I am going to talk about the Violence Against Women Act, or as it's called, VAWA. It's a federal act, but for those of you that know me, and if you don't know me now, you know that I like to tell stories. As the executive director of Waypoint Services for the last 13 years, the team that I worked with has provided me with many stories, and I think it's the best way in this case to illustrate something that's a pretty complex piece of legislation, but that has huge implications for, particularly in light of the fact that Congress has not been able to take action on it for over a year. So I'm just going to ask you to think about if you were a mom with a couple kids, you were living in a state adjacent to Iowa, and you needed to flee your partner. And so you moved to a city in Iowa, and your partner followed you, and so you moved again. And you arrived in a community here in Cedar Rapids who was able to assist you in getting housing, and getting your kids back in school, and most of all, making your life safe. Now, let's add another variable to that. Let's imagine that you are married, that your spouse is American, you are a legal immigrant here under a visa, and you are in the same situation. First of all, the threats are real that you could lose your children. The threats are that you could leave the country without your children because your children were born in America. What are your rights, and what do you do to be able to protect your status as a legal immigrant here in this country, and to be able to protect your family, and to be able to stay here and raise your children? And the reason I'm telling this particular story, because there's many things that the Violence Against Women Act has done over the past almost 20 years, and providing services not only to victims of domestic violence and sexual assault, but to people with disabilities and to families that are in need of other services, to our Native American tribes. The list goes on, and I will share a little bit of that, but I have to tell you that in 1994, this law was passed, signed by then President Clinton, legislation introduced by then Senator Joe Biden, and it passed on both sides of the aisle. It was kind of a no-brainer law, and I'll talk a little bit more about some of the things that it provides. In 2000, it was reauthorized, same bipartisan support. In 2005, it was reauthorized again, bipartisan support. Not quite as much, but still, both sides of the aisle passed. This year, we have been working since the latter end of, I lost track of what year it is, 2011 and into 2012, to get this reauthorization done, and it has been repeatedly blocked. And the reason I picked the immigrant issue is that that's one of the big stumbling points. The sad part about this is that immigration policy has bumped up against what I believe to be good legislation in the Violence Against Women Act. and it has stalled in both houses. And it's not even going to be, of course, taken up now before the election. So it's highly unlikely that there will be a bill for a president to sign after the first of the year. The implications for that are significant. Sorry, I need to put my glasses on so I don't miss anything. The Violence Against Women Act really has many, many parts. It is administered through the U.S. Department of Justice, and the funds are funneled down through the states, both through a grants program at the Office of Justice and through our state's attorneys general throughout the state or throughout the country. So at Waypoint, when we are looking at funding for our domestic violence and sexual assault services, and we serve hundreds, if not several thousand families a year in our programs, we receive a combination grant, if you will, from a variety of federal funds, including VAWA, and in addition to the support that the Iowa legislature provides us for every year. And those are competitive grants that are then out to the many domestic violence and sexual assault intervention programs throughout the state of Iowa. VAWA is a key component of that, particularly in rural areas. We're very fortunate here in Cedar Rapids. We're very rich in resources in terms of services that we're able to provide to the community, not just at Waypoint. But when you look at some of our rural programs, they are almost solely dependent on VAWA. And we are in danger of losing those funds in the future if Congress is not able to pass this reauthorization bill. But the immigration piece of this, and protection for those legal and illegal immigrant victims to be able to access the system to protect themselves and their children, is the major stumbling block in this legislation. If any of you are interested, I can provide you with a couple of websites that can give you a little bit more information. But I just want to tell you, so for those of us who are Cedar Rapids citizens or in the metro area, the funds that VAW was able to provide is, for instance, we got some money through that state grant that I was just talking about, but we applied for and received a grant last year that we applied directly to the Department of Justice for, to provide transitional housing for women who are fleeing violence. So the person that I just talked about, she's fleeing violence. She has no home to go to. She's not going to go to a shelter. She's going to be able to come to Waypoint. We're partnering with Four Oaks Affordable Housing Network to provide immediate housing for that woman and her family for up to 2 years. In addition, we're partnering with other agencies in the town, Legal Aid and Goodwill, for job training. We're working with these families to help them heal and become self-sufficient. Without VAWA, that wouldn't be possible. Another VAWA grant that the community received prior to the flood was a grant called Safe Havens Grant, which was to provide supervised visits for families who are in turmoil and who the court has ordered supervised visits for one of the parents, a safe place for those children to be able to have that exchange. So what I would ask you is that while our delegation in Washington, D.C. has indeed in the past, and I'm going to reference specifically the Senate right now, both senators for all of these years have voted to support VAWA, and this year one has chosen not to. I think it is very important that we have conversations with both senators. I've been talking with some of the members of our congressional delegation, in particular, a couple of our congressmen in this area. We do have good support, but it's not going to be enough. So I'll be happy to take questions later. Thank you.
Thank you, Liz. Our last speaker is Katie Jones from Lynn County Public Health, and she will speak on women's health issues.
All right, so I'm going to give a bit of a background about Title X, the family planning program, and then I'm also going to talk about other sources of family planning funds in Lynn County, and then talk a little about the Sexual Health Alliance of Lynn and Johnson counties. So, okay, closer, sorry. All right, can you hear me now? Okay, sorry. So Title X family planning program, I'm just going to give some facts about it, but what do people think of when they hear Title X? what comes to mind? Birth control? Anything else? Richard Nixon, yeah, it actually came about in 1970. Richard Nixon was behind it, which is interesting. So it's actually part of the Public Health Service Act. It's been around since 1970. Some, I think, common misconceptions about it. One of the big ones is that it funds abortion, and it actually has never funded abortion. It does fund Planned Parenthood, but the funds are restricted and cannot be used for abortion. But it does cover a lot of other birth control, contraceptive services, and things like cancer screenings, and also health education and even community education, so it doesn't just provide services. It serves about 5 million women in the United States across the country, and it's a federal grants program, so it's run by the federal government, but they give grants to different clinics across the country. There's about 100 grantees across the country, and a lot of them have satellite clinics. The Title X grantee in Lynn County is actually St. Luke's Hospital, and in addition to their hospital location, they have about 8 satellite clinics. So it's a competitive process. They provide contraceptive services, education counseling, breast and pelvic exams. So that's another example. It's not just birth control. It's also breast and cervical cancer screening, STI and HIV testing, and then also pregnancy testing and referral. So the fees are based on an ability to pay. That's another thing. It has a priority on low-income people. So if someone's in Medicaid, it's free. If people are below the federal poverty guidelines, it's also free. And then there's the ability to pay, so based on how much you make. Usually the services are cheaper than the alternative. So there's some statistics on the Planned Parenthood website that over the past 2 decades, it's prevented about 20 million unintended pregnancies, this funding has, and the rate of teen pregnancies would have been about 20% higher during this period. And also, it's provided about 57.3 million Pap tests, which one study estimated would have resulted in the early detection of as many as 55,000 cases of invasive cervical cancer. But Title X is not the only source of family planning services, and actually Medicaid is the largest single source of public dollars that support family planning services. And through Medicaid, a bunch of family planning services are required, but it does vary by state what exactly is required. In Iowa, quite a lot is covered. This includes any prescription or over-the-counter contraceptive method, tubal ligation and vasectomy, contraceptive counseling, HPV vaccines, things like that. So Medicaid is another source of family planning services. I also wanted to highlight one Iowa-specific grant that doesn't provide family planning services, but it does complement them, and it's called the Community Adolescent Pregnancy Prevention Grant, or the CAP grant. And this is just kind of a neat program. It was created through the Iowa legislature through the Department of Human Services, and there's 23 grant holders across the state that serve about 60% of the counties in Iowa, and this provides evidence-based pregnancy prevention programs. So the Planned Parenthood of the Heartland in Lynn County is the holder of this grant, and they have trained health education specialists that provide sexual health education that's evidence-based, which means that it's been thoroughly evaluated and has shown to be effective, and they can provide that for free to schools. So that's kind of a really neat, interesting grant that is Iowa-specific that's here, available here. In addition to St. Luke's, the Title X grantee, there are many other services of family planning services here. This includes, Mercy Hospital provides family planning, also the Planned Parenthood of the Heartland. The Lynn Community Care provides family planning services, and that's on a sliding fee scale payment. And then also family practice clinics. People can go to their family practice doctor and get many family planning services. Also, Lynn County Public Health does provide some pregnancy tests. We provide sexually transmitted infection testing that's free, and rapid HIV tests, which are free for those who qualify. And also, we partner with Mercy to do the Care for Yourself breast and cervical cancer prevention program, or screening program. So that provides breast exams, Pap tests, and mammograms for those who qualify. Typically, it's those who don't have insurance and are kind of in those gaps, so it provides free breast and cervical cancer screening. I also just wanted to mention the Sexual Health Alliance of Lynn and Johnson counties. This is a coalition that was formed in December of 2010. It's comprised of community members, organizations, and advocates. It was originally created to improve the health of both Lynn and Johnson counties by reducing the rates of sexually transmitted infections and HIV. And over the past year, we now have a website. We've disseminated local sexual health resources. It's a lot about bringing professionals together to know who's doing what, and then also bringing lay people in to advocate. And we also host educational events. We actually just had one at CO for about human trafficking. That was just a few weeks ago. I don't know if anyone here was able to attend that. We had another one about HIV transmission laws in Iowa, because Iowa has some of the strictest HIV transmission laws in the country. And we also conduct outreach at local community events. What we've been really focused on now is about healthy relationships and encouraging parents to be askable parents with their kids. So that's just something I encourage you all, if you're interested and passionate about sexual health, to consider joining the coalition. And we switch off if we meet in Lynn County or Johnson County. So that's all.
So we have about 30 minutes left. We will take questions as time permits. I'd like to just start with one question that's really more of a clarification. Katie, did I hear you right that Mercy Medical Center provides family planning?
Yes, you can go to a doctor at Mercy Hospital and get contraceptive services, or just like if you went to see a family practice physician, you could get a prescription for birth control or things like that. Or and they take Medicaid, so if you have Medicaid, those services are covered too.
Because in essence, this could tie into a question or an issue that Peter alluded to relative to the mandate within the ACA to provide family planning, and specifically birth control, and the pushback from Catholic institutions, who didn't want to be mandated to do that. Peter, where are things with the ACA and that mandate?
The mandate did go into place, and I think the issue with that in many ways is similar to the issue with the individual mandate. It's in part the fact of what it's supposed to intended to do, but it's in part that nobody likes to be told what to do. And so with the ACA and the individual mandate, when you actually break it all down in the Urban Institute, which is a slightly conservative think tank, if you will, the week that the Supreme Court came out with their ruling, they came out with a study that showed only about 6% of the population actually falls into the component of the individual mandate where you would more or less be made to purchase insurance. And the thing about that is that many of those people actually want to. It's just that they're not able to currently. And so, but then when you turn it into a political issue, you've got many, many millions of people that are not really going to be affected at all, but either think they are or just don't like the idea that the government is saying you need to do this. And I think with the contraceptive issue, and again, I'm not speaking for the Catholic Church or anything like that, but that's what many of that is that it isn't even so much whether you can do it. It's like, we'll do it on our own when we want to, but don't tell us whether to do it. So what they did as a compromise is to say, okay, if you've got objections, you don't have to do it, but it'll still be covered and paid for by the insurance company rather than by the entity. Now, the reality is, does that really make a difference? Because it's kind of cost shifting and the dollars are coming from one place or another. Again, I think you could make the argument one way or another, but it did go into place, and it is the law of the land at this point.
Okay. And Maxine, a question for you. I don't recall the data relative to representation by women in the Iowa state legislature, or frankly in U.S. Congress and Senate, and wondered if you'd talk just for a minute about the 50/50 in 2020 project.
Well, the 50/50 in 2020 is a project to get more women involved in politics. And so there are training institutes that have been set up, because if one of you would decide you would like to run for public office, you may ask the question, what do I need to do? How can I get that support? And so this is a neutral group. It's sponsored by both Republicans and Democrats, and so it's politically neutral, which is a wonderful thing. And it has encouraged a number of women in the hope that by the year 2020, we will have 50% of our legislators female.
Wonderful. Okay, we've got some questions from the audience. Boy, this is some great handwriting. Thank you. Okay, this is a general question, so I'll open it up to anyone on the panel. How would you explain to friends why these are nonpartisan issues and why they should get involved in these issues? Anybody want to take a stab at that? A lot of smiles.
Well, I guess I would say they're nonpartisan because they affect all women, whether you're a Republican or a Democrat or an independent. You should all be concerned about women's issues. And if not personally for yourself, for your child or for your grandchildren, if you have grandchildren. To me, it's just a no-brainer that it would affect everyone.
Go ahead.
I would follow with what Maxine just said too, and to really address the fact that then, seems obvious, but I'm still going to say it, is it impacts families. And so for each of these issues, in my view, it's for the health and well-being of the family ultimately, and therefore, those are issues that are important, and families we know are struggling. And so each of these issues in and of itself is important, and together they're significant.
And, Medicare and Medicaid were not, I wouldn't say they passed real easily. You may know President Truman first proposed Medicare, and it took 17 years for it to literally get passed. Medicare sort of slipped, Medicaid slipped through. But the ACA, the history of that one is to me very fascinating. This individual mandate was originally put in place, many of you are aware, to try to keep the government out of health care. And the idea that it was proposed when people were talking about a single payer plan, this was a way of driving people into private insurance and was to subsidize people purchasing private insurance. This wasn't a liberal approach, if you will. If you think about a political spectrum, on the far left would be a national health service. There would be something like Great Britain, where all the doctors would be employees and all the facilities would be owned by the government. You start moving to the right, would be a single payer plan, where all the payment is government, but the facilities are still private. A slightly left of center was the Clinton approach, which was a business mandate. This individual mandate is actually a slightly right of center approach to it. And I think one of the reasons it seemed like a liberal approach is that this time around, none of these other ones were even on the table. And that was one of the reasons it was able to be passed, is because they had fewer options. People were working together much more closely than they did, say, in 93, 94 with the Clinton plan, where you had 13 different committees in the House that were all working on their own thing, and the likelihood they were ever going to come together, because you had such strong leaders of all these different committees, wasn't going to happen. This time, the Congress actually worked together closely, and this bill was really written by 3 Republicans, 3 Democrats, one of which was Senator Grassley. It was the Senate Finance Committee that wrote the majority of this bill. Probably 90% of this bill was written by 3 Republicans and 3 Democrats. Then towards the end, over partly policy differences, part political differences, they fell apart, and then it became, a very partisan issue. And, whether it's women's health or whether it's coverage of the uninsured or whether it's healthcare costs, those are not partisan issues, and those are all things that we all need to work together on.